First of all, I would like to thank Dr. Mallika Madam for having invited me in this IC with all the doyens, and like to congratulate the whole scientific team, including especially Dr.Lalit Verma sir, the chairman scientific, for having given a wonderful scientific feast in this AIOS. So coming to a few of the challenging case presentations, first I would like to, the slides are not moving. Yeah. So this was a lady who was not treated at all for PDR, and suddenly she came one day telling that I need some treatment. So this was the surgery operated under Ingenuity, and so the advantage of this Ingenuity is having a heads-up display system, and you can have a good precision and depth magnification. So now I'm doing a cutter segmentation in this case first, and then I go and attack the conformal segmentation as described by Dr. Steve Charles, and so trying to peel as much as possible, then go ahead with the backfold delamination with the cutter itself coming around. And I do not always hesitate to use bimanual surgeries, because although there is a good multifunctionality of the cutters nowadays with the most of the modern machines giving a good functionality, but still bimanual surgery gives the best result. And coming to the periphery, I was a little bit more careful, because as you see here, the retina is very atrophic, very thin, and you can see the sclerosed vessel there. So intermittently I use my cutter also to cut off the membranes once I peel this. And once I get rid of most of these peripheral membranes, and then I did a PFCL injection for me to settle the retina, and I could see the retina settling really well in this case. And I never forget to do peripheral base shaving in any of my cases with retinal detachment, and then did a laser, and then did a silicone oil exchange in this case. And this, you can see the patient improved from hand movements close to face to 624. I thought I was lucky enough to have, and what you can see is a little bit of oil reflexes. And this is another challenging case. Actually, the boy was in a blind school, thinking that because he went to many of the surgeons there nearby, and he was stated it's an inoperable case, and he went to the blind school. So once we confirmed, we were using a long needle because we do not want to go the subretinal. And once the anterior membranes were cleared, the lensectomy and the anterior PVR were cleared, and then we passed on the main infusion in this. And the trick is to get as much membranes as possible without using the biome, because we get a good visualization with the microscope itself when we are dealing with the anterior PVR, and you can even give a depression and do the dissection. And once we go inside, we see the retina is thrown into multiple folds, and there was also a circumferential PVR traction. Basically, what is described is the anteroposterior fibers, which runs from the posterior to the base of the retina to the pars plana or the iris, that causes the posterior vitreous contraction, and that is how the equator anterior gets pulled anteriorly. Now doing a fluid exchange for the retina to get open up, so that we can have a visualization of the disc, so that we can start injecting PFCL in this case. And once the PFCL is injected, then it becomes, because it gives like a third hand, like a counter resistance, so that now we can start dealing with the periphery, that is the anterior PVR. Requires more patience, but dissection is very important. If at all we cannot get away with most of the membranes, then it's always better to put a belt buckle. Did a laser and lasering all the breaks, then did a silicone oil. So this is another set of case. The previous video, I would like to acknowledge Dr. Guru Prasad for that. And this case was a very challenging case. You can see there's an intraocular foreign body with the retinal detachment. And first I thought I could get away with most of these, and I tried to separate this stone piece, which was embedded in the retina. And I slowly tried to do the dissection with the cutter itself. membrane dissection. And then when I got to know that it was no longer a unimanual surgery, then I did not hesitate to do a bimanual surgery in this case. Because as you see there, the retina was incarcerated in the choroid, and then I tried to bring back this foreign body, making a scleral tunnel. And then I could visualize that it was nearly a stone piece of nearly measuring around 5 into 6 millimeter. And then I went ahead and tried to peel as much as membranes possible, which was very close to the disc. But suddenly the patient started complaining of pain because of the weaning of the anesthesia effect. And when I went inside, it was a choroidal detachment. So I was really worried what really went wrong in this case. And the hypothesis stated that probably the injection might have gone to the posterior root and has caused the choroidal detachment. And I couldn't get away with this because it almost became an oppositional kissing choroidal. So we waited for a week. After giving oral steroids, the retina settled well. It confirmed that it was a serous detachment, not a hemorrhagic detachment. And our next challenge was to deal with this PVR. This was the new thing which set up after 7 days. And as you all know that if we leave the gas without removing all these membranes, then the PVR gets accentuated very fast and it tries to complicate the things more. So the next thing was to deal with these membranes very carefully and look at the anterior PVR there. We tried to slowly remove most of these membranes, doing a little bit of vitrectomy, but ultimately we had to do retinectomy at the end where the retina was incarcerated into the choroid, and then did a nice fluid air exchange, PFCL exchange, then lasered this retinectomy, and the boy is doing well. Now this is my last case. I thought this is the case of macular hole, where we are inducing detachment in these kind of cases. This was the first surgery done. The patient did well. This was second surgery. In fact, the hole increased from the first surgery. So the new thing which is evolving now is to induce the detachment. That is, using a 40-gauge cannula, use a subretinal fluid. So as you can see here, 40-gauge cannula is being injected and try to make blisters all around the macular hole. The aim of this surgery is to completely lyse the adhesions between the edges of the macular hole and the RPE. And that was the reason why this hole was not getting closure instead of doing even 2 or 3 surgeries. And then after doing inducing a retinal detachment in this case, once we do the fluid air exchange, almost coming to the end, madam. Once we do the fluid air exchange, you see that the retinal detachment comes to the center. So that's how the edges of the macular hole gets freed up. And that gives, once we give a tamponade later on post-operatively, then that helps in the closure of the macular hole. But the important step here is not just to leave it at the edge. You have to bring that blister so that the edges of the macular hole completely get separated from the RPE. And I'll not go into the detail of it, and just did a little bit of macular teasing. And here you can see in the 3 weeks post-op, the macular hole closed pretty well, and the patient improved up to 2 lines of vision. So I hope I was able to deliver a little bit of it. Thank you so much. Thank you, one and all.